Good morning, ladies and gentlemen. And firstly, I would like to thank Dr. Farida and her team, Dr. Fawaz and Sharjeel, for this kind invite, and also to the local industry and Siemens for this organization. So the basic thing is we'll cover the entire spectrum of clinical applications of SPECT CT over the next 2 days. So we will talk on everything what we do back home using SPECT CT. So this talk is purely based on SPECT CT and only in malignant bone disease, and then we'll go system-wise, and we will cover all the joints in the body and all the organs by end of 2 days. And from the day 3, we will take you through individual scans to see how to go through them when you're reviewing the scans. So by end of 5 days, and maybe on the 4th day or the 5th day, most of you will understand how to do SPECT CT in a nice way, so that it will satisfy your clinicians as well as your patients. And for the next 30 minutes, I'll try to cover the spectrum of radiology and bone scan, what is the current evidence of using SPECT CT, some clinical examples and challenges. Coming to the radiological aspects of imaging, the plain X-ray plays an important role. It's a mainstay, it's a first investigative procedure. And why they use it, it's quite easy and it's quick to perform, and it's available in most of the hospitals around the globe. And approximately you need at least 50% bone destruction to see whether it's a pathology is involved or not in a bone scan. And you can assess whether the lesion is a lytic lesion or a sclerotic or a mixed lesion. But it's got a poor sensitivity. Because it's got a poor sensitivity, it means that it cannot be used as a screening modality to diagnose all the pathologies. Coming to CT, coming to the CT bit, CT is widely available again. I can do most of the scans within a minute or two, and it's got an additional value that it can look both at the bones as well as the soft tissue, and also the complications related to the bone pathologies like fractures and other things, and it's also useful in assessment of treatment response. And in general, if you see lytic lesion in a CT scan, it means that it's progressive disease, but if you see a sclerotic lesion, it could be just a response to the ongoing treatment. But again, the world of oncological imaging is changed with the advent of PET CT, which will be the mainstay investigative modality in oncology. Coming to, but the only problem with the CT is it's less sensitive for detection of bone marrow deposits, and therefore we are going to slightly go to a higher level, at the molecular level, using an MRI to assessment of bone lesions. In fact, MRI can be used for the diagnosis, staging, and follow-up of musculoskeletal pathologies. And one of the beauties is it has no exposure to ionizing radiation. And of course, it gives a better soft tissue contrast, and you can assess the disease of the bone marrow. And imaging time and cost is a problem, like how many have MRI and what is the waiting list. And often it's used for other indications also, because they use it frequently for any pathology. Now the mainstay is MRI, and therefore how many scanners you have and how much cost can be put into this is the main question in our place. MRI again is less sensitive than CT in detecting cortical bone destruction. Therefore it's good for marrow, but if you want to really discuss the cortical pathology, MRI may not be the test of choice. So in general, all the radiological modalities helps in detection of presence and extent of metastasis. Pathological fracture or any complications related to the fracture can be assessed with radiological techniques. And of course, you can also helps in prognosis and assessment of treatment response. But today, we are moving into more of imaging sciences rather than telling radiology or nuclear medicine. All those individual domains will go. In future, it will be imaging sciences. So we'll have a structure. And I think the PET CT will be the mainstay imaging modality. Any oncology, they will start with a PET CT for any diagnostic. So it will be known as imaging sciences rather than separating us, putting a barrier into saying that I'm a radiologist or I'm a nuclear medicine physician. Actually, the future will be called as imaging specialist with a special interest in one of the areas of cancer rather than a modality. Coming to bone scan, that's the mainstay of nuclear medicine. It's a main common screening test also, and it's got an ability to scan the entire skeletal system. But again, you can scan the entire system with radiological techniques also now. So the definition does not helps in marketing nuclear medicine. You have to be better than that. And it's got a high sensitivity, and it's available in most of the nuclear medicine department, and in fact in 50% of the workload in majority of the nuclear medicine department is a bone scan, followed by endocrinology or renal. But the problem with its lacks specificity, but it's got a high sensitivity, but the specificity is variable. It can vary from about 7% to 70%. It depends on which indications you do and how you do it. And we also depend too much on the degree of avidity. The hotter it is, we think it's more pathological, but it is not so, because the problem is even the benign pathologies can take up tracer, and therefore it complicates your final interpretation. We are quite good in description, but if you want to come in terms of a definitive diagnosis, and that's where we may not be that good as we have imagined in the past. And especially if it's a solitary lesion like this, then it's become challenging, because bone scan is evolving, especially in oncology. When last time when I came, we were talking about MDP, and then people said it's going to change, it's going to be fluoride. Fluoride is going to be an important aspect, but in terms of prostate cancers and other things, where they're going a little bit more ahead with gallium labeled PSMA or the technetium labeled PSMA, that's going to be the future. In fact, a few hospitals which I know in India, they've even stopped doing bone scans for prostate cancer patients. They directly go to gallium 68 PSMA because it can show both bone lesions as well as lymph nodes and soft tissue metastasis. So we have to come to an algorithm, like how we are going to image a patient, especially in prostate cancer. The research into assessment of these patients is growing extensively, not only from the molecular imaging or the nuclear medicine side, even from the radiological side. They're going into the diffusion weighted MR. If you go to an MR specialist, he says that he can solve all the problems with diffusion weighted MR. He can tell anything. So therefore, things are changing. So we have to be very careful how we use the technique, and what stage we use and what indications we use. So we can't use it randomly. So that's why I think the role for bone scan in future more will be in non-oncological indications rather than oncological indications, because for oncology it's expanding tremendously. In fact, a lot of new traces, new technology. So if someone wants to really expand the SPECT CT service, the market is in the benign pathologies. It's got a huge market in benign pathologies. And if you have a solitary lesion like this, then it becomes challenging for nuclear medicine people, because the clinical question there is, this patient has got cancer and they want to know whether it's a metastasis or not. Then, if we are the junior most, we can say, okay, possibly metastasis, because everybody thinks nuclear medicine means oncology. If you do a bone scan, if it's hot uptake, then they think it's pathology. But often we get into this trouble. The more we read, the more confused we become. And then the clinical question is whether this mets, and some will say this is suspicious for bone metastasis, and some will sit on the fence, like, it looks like benign, but I would like to have further investigations to confirm whether it is benign or malignant. And we have two cameras. So we have a President 16 slice, which is one of the first cameras in the Europe, and recently for the last 2 years we have a 16 slice Siemens SPECT CT also. And the basic question as nuclear medicine physicians, we need to know what is the evidence, like how much you can expand your role into doing SPECT CT in your department. And for the referring clinicians, he's not interested in what technology you use, he needs an answer, final answer to say whether it's good or bad, whether it is disease, benign or malignant. And for the patient, they need an accurate and early diagnosis. That's all they need. They don't are interested in your pictures or in your imaging protocols or anything. They want an outcome. And as nuclear medicine physicians, we have to satisfy all the 3 points to provide better service to our patients as well as to our referrers. What we do in nuclear medicine at our hospital is generally for oncological patients, we don't vet them for SPECT CTs. Usually we go for a conventional whole body bone scan. Based on the bone scan, if it's straightforward, if it is multiple mets, we don't have to do a SPECT CT. The problem comes when there is a solitary lesion, or sometimes there is a patchy uptake in the spine. If you want to confirm definitely whether it's benign or malignant, then we do a specific site, a CT on the SPECT of that particular area, and we come to a definitive diagnosis in that. So in general patients with oncology, we don't vet them for SPECT CT, because after the whole body scan, we review the scan and then we decide whether we are going for a SPECT or a SPECT CT. Whereas for all orthopedic cases, every patient who's got a post-surgical, they will all go for a SPECT CT from the start. So it's already been recognized. They play a significant role. for the next 2 days, we will show how it's going to help in non-oncological pathologies, especially in orthopedics. So that's what we do. That's what I said. We just review the scans, and if you think some site is indeterminate, whether we can't say whether it's benign or malignant, then we go for a SPECT CT. Coming to bone SPECT CT, I've told so much, and then you'll ask what is the evidence, how I'm going to convince myself as well as my referrer. This is one of the first papers which come in. In fact, the SPECT CT technology was there for quite a long time. People used to merge the hardware component. They used to do CT as well as they used to do a SPECT in different cameras, and then with the help of a physicist, they had to merge the cameras. That was the hardware fusion which used to be there for quite a long time. But in somewhere in 2005, which is the first one of the software technologies like the hybrid camera which came in from the GE as a single slice Hawkeye camera which came in, but later on people developed multi-slice CT, and at present we can have a very good CT component studies. So in this patient, they looked at around 40 patients. In that SPECT CT correctly classified 85% of indeterminate lesions, because at least when you do a whole body bone scan, most of it, if it is a solitary lesion, especially in the ribs or on the spine, it's 50-50. Either you can go that side, this side, depending on the clinical scenario. And in fact, by doing the SPECT alone, they could have only proper diagnosis only in 36%, but by using the SPECT CT, they could classify 85% of them as definitely benign or malignant. This is another paper from Homer. He looked at 57 patients. It's a retrospective study, 52 indeterminate lesions in 44 patients, and in fact by using SPECT CT, he could say whether it's benign or malignant in 92% of their patient group. And we do have problems, especially if it is in the scapula or the ribs. So in spite of having SPECT CTs, we can't really say whether it is a benign pathology or malignant. So still we have problems in about 8 to 10% of the patients to definitely give the answer, but in about 90% of the cases we can be definitely sure and confirm whether it's a benign or malignant and be definitive. This is from our group. We looked at around 48 patients, and we made definitive diagnosis in about 83 out of the 95 indeterminate lesions. And again, we had problem only in few patients with scapular and rib lesions. So SPECT CT does make a definitive impact, and it 90% of the times it gives you a definitive answer. And this is one of the largest studies. They looked at 141 lesions in cancer patients, and in fact if you see the sensitivity, SPECT CT has got around 98%, specificity around 94%, and you got an accuracy about 96%. By using SPECT CT, I would definitely say in more than 90% of the patients you will definitely give a very good report which is convincing, and it will help the patient management effectively, and also it will avoid more investigations and more anxiety to the patients as well as to the clinicians. Coming to a scan like this, it's straightforward. You can say it's METS and leave it, but in this case if you ask me why you have to do a SPECT CT, I would say I wouldn't have done a SPECT CT, but by doing the SPECT CT you can definitely localize. That's the only thing I'm doing there, but it's not helped me in terms of diagnosis. I can easily say that could be all metastasis, but the only problem is if the patient has got an additional history that he's fallen few days ago, then it becomes challenging whether it's traumatic or it is bone metastasis. Then it will make me slightly worried. Then I would ask for a SPECT CT. But in this case, if you ask me, you would have done a SPECT CT, I would have said maybe, depending on my workload. If there is no patients on a particular day, then I would say okay, let's do a SPECT CT. But if it's a busy day, I would say I know that it's METS. Even if I overcall or undercall one lesion, it's not going to change the patient management. Therefore, I would have gone and said it's all bone metastasis. Then it becomes challenging like this. This is a patient with breast cancer. You can see some patchy uptake in the neck, which I'm not that much worried in most of the scans. There are some subtle heterogeneity again in the pelvic region. And by using a combination, I'm seeing is there is a sclerotic lesion and there is a facet joint degeneration there, but I'm not sure whether it's real. And then there is a sclerotic lesion again here. But the combination of the SPECT CT technology, and that turned out to be a facet joint disease, that's the metastasis. This is the metastasis, but it's not metabolically active. So this patient is on a treatment, so therefore some lesions, see if it becomes strictly very well sclerosed. For example, if the Hounsfield unit is around 200 or something, it will look normal on a bone scan. So you should not underestimate or overestimate based on just the sclerosis. And the question again is indeterminate lesions, whether it's malignant or benign. This is again patients with cancer. There are 2 lesions there. The clinical question is whether both are degenerative, both are benign, or one is metastasis or one is degenerative. But the combination, you can see it's not projecting well, but I can see it very well here. But there is a lytic lesion, a huge lytic lesion with some sclerosis there, and that's quite more posterior. That turned out to be facet joint disease. So there was a combination of bone metastasis here and facet joint disease in this region. So we can be very specific to say which area there is degenerative changes and which area there is metastatic disease. This is again a patient with previous lung cancer. The clinical question was whether it's bone metastasis, and how many will go for bone metastasis in this, especially when you're concentrating on that lesion. How many will go for bone metastasis in the audience? Very few. Nobody wants to say it's Mets. Is it degenerative? Okay. With the SPECT CT, yes, that turned out to be facet joint disease rather than bone metastasis. But again, it depends on how much experience you have. If you go from the first year, second year, third year students, I would always sit on the fence saying that because the patient has got cancer, then I will say it could be benign or could be malignant, but without correlative imaging, I would not just pass it out as it is normal, it's degenerative. But you have to be quite brave on a bone scan to just let this off as benign. So you have to have some correlative imaging to make a definitive diagnosis. This is again a patient with renal cancer with back and hip pain, and I've already given the diagnosis here, but there's a patchy uptake here which I'm not that much worried, so that could be metastasis. But again, looking just as the whole body bone scan, I'm not seeing nothing convincing to call something pathology in the hip region. It looks more or less, but the patient has significant pain there, and if you could see on the CT component there is significant loss, and there's a huge lytic lesion with the potential to fracture, and this patient had a large lytic bone metastasis at that site. This is another patient, quite a young patient, who was an executive in a multinational company, and she had a blurred vision, left eye photopenia, proptosed eye. They did x-rays, they did all the investigations which was not conclusive, but just they asked for a bone scan because she says she's got generalized body ache, and this is what the bone scan looked. No other investigations were done. She just walked in for a bone scan thinking it would be just degenerative or something is happening. And if you could see, there are multiple lesions in the spine, all turned out to be bone metastasis. And what is more interesting is on the CT component, she's having lung lesions also, metastasis. But only thing is we have yet to confirm what the pathology in this, though it looks like a malignant pathology, but we don't have a definitive diagnosis, but we are still waiting for the biopsy to see where the primary pathology is. She just walked in, she's just 37-year-old, working every day, and she had some blurred vision, and over a period of time she was losing the color sensation, and then we did a bone scan, and this is the pathology, which is quite unexpected. And this is again a pediatric patient, mid lumbar pain, spinous muscle, and there is a focal uptake there. So what you're going to say, but again it's not projecting. But on the SPECT CT component, there is a soft tissue lesion here which is not taking up the tracer, but that turned out to be just a facet joint disease. That is a facet joint disease, but adjacent to the facet joint disease there is a soft tissue uptake which was a tumor in this particular patient. Pattern recognition, because we often, in fact majority of the radiology is pattern recognition. Usually you know that's the pathology, and you pick up based on you have seen it so many times, and therefore this is likely to be this. But if you use the same formula in nuclear medicine, we used to use that, we always use it, pattern recognition, as an intuition. My gut feeling says that this is malignant or benign, we always use it, that's normal. But with SPECT CT, that has changed our perception that guessing is not good, so we have to be definitive. And these are the few examples. 2 patients, one with prostate, one with breast cancer, looks more or less similar. So in this case, if you want to know whether it's benign or malignant, it is like tossing a coin. One turned out to be, there is a sclerotic lesion here with sclerosis, and that turned out to be bone metastasis, whereas on this aspect it looks quite similar, but it's an end plate changes with some sclerosis with joint around this area. So similar lesions, but one turned out to be metastasis, the other turned out to be degenerative. So by this then we can definitely say the diagnosis whether it's degenerative or benign, and we can go home happily saying that I've done something good, rather than saying I reported this scan but I'm not sure whether it's benign or malignant, let's wait for the CT for the opinion or something like that. This is again 2 cancer patient, focal uptake, benign or malignant? Benign? Malignant. So it's again 50-50. As soon as one person says benign, one says malignant, then it means they should be voting. Similar lesions, it's benign or malignant? Benign? Malignant? Okay. In this case, the first one you said was benign, was a malignant, and when you said this was a malignant, was benign. So that was degenerative changes. There's a sclerotic lesion there. The first one turned out to be bone metastasis. The other one turned out to be degenerative disease. So it's like tossing a coin, 50%. You can be right, you can be wrong without SPECT CT. But with SPECT CT, 100% of the time, you will get a definitive diagnosis. Coming to focal uptake, again pattern recognition. In the past, like in a patient with prostate cancer, if there is a focal uptake in the pelvis, you have to be quite careful. It is exactly like patients with breast cancer. If you see some sternal uptake, you can't just pass it out as a normal scan. You have to be always cautious about sternum uptake in a patient with breast cancer. Similarly, in patients with prostate cancer, you should be careful about a focal uptake in the pelvis. So whenever we see a focal uptake in the ischium, we used to get excited. So we used to over-report saying that, oh, there is a METS there, METS there. But with SPECT CT, we changed the entire opinion. It's not my opinion. It was, we all learned from Fogelman, who is the Pope of bone imaging. So whenever I see a focal uptake, I used to say it's METS because it's pelvis, the prostate is in the pelvis, it's close to all the bony structures there, so it has to metastasis there. But we changed our opinion after the SPECT CT. In fact, 68 patients were diagnosed with widespread disease, so we didn't worry about them. We were just worried about the 36 patients where we had indeterminate findings. In those patients, we did SPECT CT, and out of the 36, 10 people had focal uptake in the ischium. And without SPECT CT, we would have called all those 10 patients as suspicious for bone metastasis. Means when you say suspicious, means they get investigated further. But with SPECT CT, only 3 out of the 10 were diagnosed to have metastatic lesion, and 7 of them had degenerative. And this is how it looks like. There's a focal uptake there. What are you going to say? Nothing elsewhere in the body. There's a focal uptake there. How we would have called it? We always say, so if it's bilateral, then it's not going to be that much of an issue, because anything bilateral in nuclear medicine, we always underplay it. Only when it is focal, unilateral, then the problem is, especially solitary, and the PSA is borderline, and you want to say definitely whether to go for a surgery or not to go for surgery, and that's where the dilemma is. So in this case, the first one, there was a focal uptake there. We'll go from this side, bilateral focal uptake here. It turned out to be insertional enthesiopathy. That was again a unilateral enthesiopathy, which is just an reaction around the attachment. And the last one turned out to be bone metastasis because there is a sclerotic lesion there. So focal uptake here. Now with the SPECT CT, we can be very clear. If there is no bony cortical changes there, you can bravely say it is due to insertional enthesiopathy, not bone metastasis, and therefore the patient can have further treatment related to their prostate cancer. Limitations of planar and SPECT. The problem with the planar is, in this case, this is a patient with prostate cancer, patchy uptake. How many will go for degenerative disease in this? Degenerative, PSA of 14, 15. Equivocal, probably METS, probably degenerative. Okay. If it had said that, I would have agreed, because I wouldn't have asked for it. If it was some other day, I would have said, okay, it's all these are suspicious. You would have said probably metastasis, but fortunately, all this turned out to be just osteophytic changes and facet joint disease, and it was all degenerative. What was thought to be metastasis changes over completely to degenerative disease. So that was a significant diagnosis. Nobody can diagnose based on your whole body bone scan. This is again a patient with prostate cancer. The clinical question is that a bone metastasis? Using SPECT CT, I can definitely say one was a bone metastasis and the bottom one was a facet joint disease. So I can be very clear which is METS and which is degenerative. But without that, I would have said both the lesions are metastasis, end of story. Because it helps to clarify from the start, especially if it's a baseline scan, because you can, over a period of time, the facet joint disease may show reduced uptake, and if you don't know that was the facet joint disease, you will say there is a good metabolic response to treatment. treatment. But what you're saying is the degenerative disease has resolved, but not the metastasis. So if you don't know which is mets and which is degenerative, you're giving a false perception to the surgeon or the physician, saying that the patient is responding to the treatment. But in this case, he's not only the degenerative disease is becoming normal, but the metastasis is stable or it is progressed. So by doing SPECT CT, we can definitely tell which is degenerative, which is metastasis. Okay, sure. It's not projecting, that's why we can't, like, that one is lights, because it's becoming too dark. You see, I can see her very clearly. I want same one, because here I can see. It's a projector, because here it's so clear. Here it is clear, it's very good here. I can see what I am talking. Shall we go ahead? Maybe after the tea time we can organize, set up this. And if you can see, that is the sclerosis in the body of the vertebra. So if it's in the body, then it's more likely to be metastatic, that is sclerosis, whereas the sclerosis patchy here is attached to the facet joint disease. So if it is in the joint, it is definitely going to be facet joint disease. If it is in the body, then it's going to be, could be, if it is the periphery of the body, it could be that end plate changes and other things, but if it is the central body sclerotic lesion involving most of the vertebrae, then the diagnosis should be metastatic disease in this. So in this case, what was thought to be both to be malignant, one turned out to be benign and the other turned out to be metastatic disease. Therefore, we give a definitive and a confirmative diagnosis in these patients. This is again a patient with prostate cancer, increasing pain in the right ischium. So on the bone scan, I think it's a normal scan. Can anybody find anything in the bone scan? Ischium looks fine. But as soon as you do the SPECT, there's a focal uptake in the ischium. Again, you can say it could be contamination, could be anything there in the ischium. But on the CT, again, it's not projecting well. There is a sclerotic lytic lesion around this area. Even on the MR shows a lesion in the ischium. So what was normal we could have passed on turned out to be metastatic disease, because you have done a SPECT and also the CT component adds to the diagnosis. So what was normal on a whole body bone scan, we changed the entire diagnosis. The patient's got a solitary mets in the ischium on the right side. Coming to definitive reports, that's what the clinicians like. Whether it's benign or malignant is the final question, because even though you may describe it into 5 lines or 10 lines or 20 lines, most of the clinicians will not be interested to read the entire spectrum. All they need is one line, whether it's benign or malignant, whether it's infection or no infection, whether it's loosening or it is infection. So this is a incidental finding. We have patient with a low back pain, pain in the right ankle. Patient has a previous history of cancer. The clinical question was whether there was bone metastasis. The bone scan looks overall fine. There's a full bladder. In this case, you can say the diagnosis could be a prostate cancer, but there's a focal uptake there close to the ankle joint. It's very rare the patient will have metastasis in that area. Solitary, isolated metastasis is very rare, although there are a few case reports. But in this case, it turned out to be a lesion with sclerosis with lucency in the center, which is a classical finding for bone infarct. So it's very unlikely to be a bone metastasis because nothing is there elsewhere except there is some cystic changes in the left kidney, but elsewhere there is nothing. It's unlikely to be a solitary metastasis around the periphery. This is again a patient with breast cancer. More or less it's quite okay, except for some patchy uptake there. Again, we would have said it's likely degenerative. There is no convincing evidence of bone metastasis in the study, but doing the SPECT CT, doing the SPECT, you are picking up all these focal lesions because of better resolution, and you're seeing focal uptake there. On the CT bit, there's a sclerotic lesion there, if you could see. That's a sclerotic lesion, and that turned out to be a bone metastasis. Sclerotic lesion, what was found to be equivocal or normal on a whole body bone scan. By doing a SPECT CT, you are making a definitive diagnosis, upstaging the disease from normal to abnormal. This is again a patient with lung cancer, uptake in the neck of the femur. The clinical question is whether it's benign or malignant. Again, there's nothing much going on elsewhere, because lung cancer is quite challenging because it can go anywhere, and the lesions can be osteolytic or it can be blastic, most likely osteolytic. But in this case, on the CT component, we didn't see any osteolysis or any blastic reaction, so that was turned out to be what is called a degenerative disease. Otherwise, if it was a cancer patient, whenever I see something like that, especially if it is a lung cancer or in a breast cancer, you have to call the orthopod or the radiology department to exclude any impending fractures. So if it was prostate, especially the sclerotic metastases are rarely fracture, because it is more like a concrete. So in patients with prostate cancer, if I see a focal uptake in the neck of the femur or the shaft, I'm not that much worried. But if I see some uptake in the shaft of the femur or the humerus in a patient with breast cancer, you need to call the orthopod or the clinical team to do a local x-ray, or if you have a CT, then you have to say whether there is a fracture or an impending fracture, because it changes the entire spectrum of management. But if it's a prostate, you can always underplay, because it's a sclerotic lesion. It's less likely to break, because it's more like a concrete. Coming to lung cancer, again the question here was whether the patient's got bone metastasis, and going back here, there's hardly anything there. It looks like a normal scan, so except there is a rib uptake. The rib uptake which is solitary, which is again non-specific. But by doing SPECT CT, it changes the entire spectrum in this patient. There is again sclerosis in the iliac bone, and then as soon as you see the sclerosis, then this fellow becomes suspicious. The rib one becomes what was, you could have just said post-traumatic, or it's non-specific, because you're seeing another lesion there which is sclerosed, and that is definitely metastasis. And then we do a SPECT around CT around this area, there is again sclerosis here. But the same sclerosis, in absence of this lesion, you can underplay it, saying it could be just post-traumatic or a healing fracture or something like that. But you see an extra lesion which is sclerosed, and that is definitely bone metastasis, then you upstage, there are two sites of metastasis. What was equivocal becomes a definitive diagnosis. This is another 34-year-old lady with generalized body ache, and X-ray shows marked osteopenia. So they said, it's just a young lady, not working too much, and these are fractures of alpha-alpha, therefore she's osteopenic or osteoporotic, and they started treating her, thinking in terms whether she may have osteopenia or osteoporosis. They do a DEXA scan. So that's what we moving. It's coming here, it's not coming there. Stuck.
And what you want now?
Next one.
And this one?
Yeah.
You have to go for full screen.
Yeah. Yeah, that's fine. That's fine. So we did a DEXA scan. So the diagnosis was back pain, previous vertebral collapse, and it is minus 4.3, straightforward osteoporosis. They were started treating for osteoporosis. Again, patient had persistent pain. Then the clinician asked, why don't you do a bone scan? So we did a bone scan. Bone scan looks more or less okay. I will not worry too much. There's some patchy uptake in those areas, but otherwise more or less this we see very often. That's normal. Patchy uptake, dental uptake is more or less benign dental pathology. except for subtle inhomogeneous uptake. That's quite a non-specific. Then you do the CT, you do the SPECT, then again it's heterogeneous, it's non-specific. And if you do the CT component, if it projects well, there is a lot of osteolytic lesions around entire spine. So what was thought to be normal, the patient went on to have myeloma. So what was started as a plain X-ray, osteopenia, went to osteoporosis with a SPECT CT. Definitely, though 35-year-old, it's very unlikely. Now people will say she's very young to have multiple myeloma and other things, but the biopsy results was patient had multiple myelomatous lesion of the entire spine, and a definitive diagnosis of myeloma was made. This is a patient which came last week. I'm still waiting for the diagnosis. The multiple bone metastases. Is there anything you see other than the bones? Sorry? Uptake in the liver. Anything else? First I thought, yes, it's uptake in the liver. I was thrilled because often we see this in patients with breast cancer, with liver mets, or with any other cancer like colorectal with the bone scan. We see liver mets often takes up, but this was not liver, it was in the lung. Okay. There's a lung lesion, there's a consolidation, but the uptake is not around the consolidation, it's around the periphery of the consolidation. So we said it could be primary, so we are awaiting the diagnosis. So these are the things we can pick up when you do a complementary investigations. Otherwise, I would have said bone metastasis, but do further investigation to clarify whatever the pathology is in the chest. But again, my first thought was, as soon as I saw, I thought it's the liver. That's what it looks like, because there is a lot of papers which has come out that there will be uptake in the liver, but also in the lung. But often we see that in malignant pleural effusion where there is a diffuse uptake, but solitary uptakes, it varies from patient to patient. And in this case, it could be a lung primary, or it could be patient may have a dual pathology going on in this patient. So SPECT CT also brings in questions and dilemmas, so that it adds to a definitive management strategy later on. Limitations, again, most of these studies is retrospective, but again, a lot of people are doing prospective studies, and there is no gold standard to compare except for the follow-up and to see how the patient has changed, because MR is again not a gold standard. And the only problem is additional radiation, but you can justify it's not additional radiation. The patient is getting a definitive diagnosis. If you don't diagnose it, patient is going to have multiple CTs over a period of time. So better to have one CT and save further investigation rather than keep talking about radiation. I don't think so. It's going to be that much of a problem if the patient's got a cancer. But if you justify you're going to give a definitive diagnosis, then it's better to do at a one-stop imaging rather than doing multiple investigations and delaying the diagnosis rather than giving a definitive diagnosis. Training is important. Training is, again, it's a self-learning. People like us come and teach, or I learn from you. That's all. It's a two-way process, but you need to have your own discipline, like how you are going to improve your CT or how you are going to improve the SPECT CT. You have to spend your time. There are excellent material in the internet, so you don't have to, I don't have to come and give a symposium. It's all there in Radiopedia. If you go to Radiopedia, there's exhaustive literature. If you want to know any pathology, click on that. The clinical example is there on the CT bit. So unless you put an effort, it's going to be challenging irrespective. We took nearly about 6 to 7 years. Still we are learning, especially orthopedics. It's always challenging. It's never the same. Every scan is different. And of course, radiation is the question, and people perform a range of hybrid cameras. So every protocol varies and what they do. Newer system capable of high resolution diagnostic. The first question you have to ask when you're doing a CT is whether you want to do a CT just for localization or you want to do for characterization. If you want to characterize the pathology, you have to do a diagnostic CT. So you have to have a better CT. But if you want to just localize, for example, in sentinel nodes and other areas, your main thing is mainly localization, not diagnosis. All you're going to say it is close to that particular muscle or particular organ, then you can do a low dose one. But again, the definition is not clear. People say diagnostic, low dose, high dose. It doesn't mean anything, I think so. It depends on individual perception. Like even with 4 slice, people used to diagnose. Now it become 16 slice. So when you can diagnose at 4 slice confidently, so why you want to say that as non-diagnostic just because you have a 16 slice CT? So it depends on your local expertise and what you want. But I would recommend a diagnostic CT for most of the orthopedic conditions. For the benign, in this case, like for malignant patients, you're more in terms of localization, exactly where the pathology is. You'll see some sclerosis. Most of the time, you'll get off with a low dose CT. But if you want to do a high quality orthopedic with multiplanar reconstruction and volume rendering and all sorts of fancy things, you need to have a high quality CT. Therefore, you can avoid more investigations, and you need to ask your radiologist also to have a brief to say which is the best quality CT we can provide on this basis. And talk to an orthopod. That's the most important thing. So he will tell exactly what he wants from the SPECT CT. Because if you could satisfy the orthopod, everything, the perception will change how you use SPECT CT. So what does SPECT CT do in oncology? This is only to oncology because there are another 15, 16 talks going on for the next 2 days. So we'll cover every aspect. But in terms of bone in patients with oncology, it helps in localization. That's how we started at. We thought it helps in localization. But more and more we are helping in characterization. It is increasing our specificity. And what is more important is we are giving a definitive diagnosis. Gone are the days we will say, correlate with CT, correlate with all those things. Now, in nuclear medicine, you can definitely tell whether the patient has got malignant disease, whether the patient's got metastasis, or it's just degenerative disease. So that's what gives you more confidence and more positive vibration. When you come to the department, you know that with the SPECT CT, most of the time I can give a definitive diagnosis. Limits and directs further investigation, unnecessary other investigations, waiting time, and all those problems can be avoided. Reduction of equivocal reports. That's what I keep telling, like we can give a definitive diagnosis, it's benign. Even though if you're not sure, you can at least call the patient 3 months later and do a bone scan for a particular lesion. But in 90% of the cases, we always give a definitive diagnosis, which is of just 2 lines. Description can vary. How you describe a report, it varies from individual, but the diagnosis has to be few lines, very specific to the clinician. Thank all my teachers. As usual, I do that as a routine. And thank you all.